Our next speaker is our keynote speaker. Her name is Mary Jean Brown. She's a former chief of the Healthy Homes and Lead Poisoning Prevention program at the CDC, and she's currently on the faculty at Harvard Chan School of Public Health. She works regularly with other agencies such as the EPA, HUD, and the World Health Organization, and she's published more than 100 documents. And she knows, we had dinner with her last night, and she knows everything. So please take it about lead. She's been doing it for over 30 years, and she knows everything. So let's welcome Mary Jean.
Thank you very much, Claudia. It's a pleasure to be here today. And like your teenage daughter, I know everything. So I have actually been in the lead business for a very long time. It'll be 38 years in January. So what happens when you age into a certain area of expertise? I mean, after a while, you better know. If you don't know everything, something's wrong. So I also want to congratulate you. As I said, I've been in this business a really long time. I have never seen a state or a county get to the place that you are at in such a short amount of time. So to be able, sometimes it takes as long as 5 years to get the housing and the health people in the same room to talk to each other, right? That's not unusual. This ABP, that is what a tremendous opportunity to bring the healthcare community into this whole effort. It's just, I think it's really remarkable, and I really want to help keep track of this MO4 project because I think you would be a model for the country. So let's continue to work on that. Today I'm going to talk about childhood lead poisoning in the 21st century. Excuse me. My first thing is, no, it's not over yet, but we can, so the seductive thing about lead poisoning and why people who do it don't ever get away from it is because you can see how it can be over. And there are very few health conditions where that's the case and almost no environmental health conditions where that is the case. So we probably could eliminate childhood lead poisoning as a public health problem over the next decade or so. Now, I've been saying that for 30 years, but the reason I say as a public health problem is because there is lead in the environment. It's a naturally occurring element, and there will always be children who have somehow gotten exposed to lead and maybe have very high blood lead levels. So we need to preserve and institutionalize the knowledge around childhood lead poisoning. But as Randy will tell you and others in the housing world will tell you, we need to integrate childhood lead poisoning into a broader approach to making our housing healthy so that housing does not have a negative impact on people's health. So this is a disclosure. I am at the School of Public Health at Harvard, but I also provide technical assistance to a wide range of people, including the Meridian Biosciences, and they pay me for it. So I'm not here to support their product, and I am not going to talk about it in my speech today, but if you have any questions, I'd be happy to talk to you later. I also do not speak on behalf of the U.S. Centers for Disease Control and Prevention, which is a vast relief to both of us. So, Florence Nightingale. Now, if you look at this picture of Florence Nightingale, I'm a nurse, and so I am Florence Nightingale, one of Florence Nightingale's millions of natural daughters. I love this picture because if you've seen the pictures of her, she often looks like a cherubic Victorian maiden, or she looks like a cherubic Victorian elderly lady. This is what she looked like when she came back from Crimea. And you can see there's fire in her eyes, and she was angry when she got back from Crimea. And she started talking about things well beyond the care of individual patients. And what she said was the connection between the dwelling of the population, the health and the dwelling of the population is one of the most important that exists. She was reflecting on the lower picture that you can see here, which is These were called rookeries. They were slums in the early industrial England. They had no windows, they had no plumbing, they had no running water, they didn't have doors that locked. They were horrendous places to live. The other picture there is, again, my pitch for thinking about healthy housing. This is an actual staircasing that I took a picture of in Rhode Island. I saw the house. The whole house looked with the peeling paint just like that staircase. And I ran and got my camera. Well, really, I came back a week later. They'd painted the house, but not the stairs. So I'm going to tell you how you can spend $1 and prevent 3 things, right? So if you fix that stair rail or you replace that stair rail, you will prevent lead poisoning, right? So $1, 3 things. Economists will tell you you can't do this. Number 2, that it has dry rot. That's the wood in there has dry rot, which is an allergen, right? So you replace it now. The second thing. And the third thing is that they didn't use steel nails, they used iron nails, and iron nails tend to rust in situations where they're outside. So then the hole gets bigger around the nail because it's rickety, so that's a trip and fall hazard. So if you decide to think holistically about housing as a fulcrum for helping people be healthier, you can get a lot done with a little bit of money. So this is basically my lead is bad for you slide. I think if you didn't believe that, you probably wouldn't be sitting here in this room. And there's a typo here. At 20, that should say decreased nerve conduction velocity, not increased nerve conduction velocity. We know that children untreated, when blood levels are very elevated, we know that the lethal dose, the point at which 50% of children will die, is around 150 micrograms per deciliter. And about 10 years ago, we confirmed that in a vast fatal outbreak of lead poisoning in northern Nigeria. But most of the children that we're concerned about in the United States nowadays are going to be, see if I can get this to go, right here, around here. And there's no known level at which some children are not going to have a problem because they've been exposed to lead, right? So the symptoms are subtle. If there are any symptoms at all, they're easily confused. Most children's blood lead levels are elevated around 2 years of age, 18 months. They could, if they have symptoms, they could be a little crabby, they could be tired, their appetite might not be good, they're not eating right. You know, if you know a 2-year-old, you will understand that sometimes that's a good day for 2-year-olds, right? So we can't really look at them and say, oh yeah, that one, he's got it. So, but certainly, I think the overarching goal that we're approaching in the United States now is to try to prevent children from having blood lead levels of 2 micrograms per deciliter or higher. Prevent that, not treat that, but to prevent that. So this is a very nice infographic that was done at CDC, and you can get it at the website. But we know that it lowers IQ, decreases ability to pay attention, and causes underperformance in school. In public health, we are all population scientists, right? So this is probably the big tragedy of lead poisoning in today's world. So if you look at this graph, the red curve is what you would expect in a normal population, right? IQ is centered at 100 in the population. And look what happens if you shift that curve by 5 points. So that's what happens when a child's blood level moves between 1 and 10. You shift that by 5 points. It has a small impact here, but look what happens here at the edges of the distribution. So if you shift it 10 points, which is a little bit easier to see, you end up increasing the number of children with IQ scores between 50 or 70, or what's now labeled intellectually disabled, has doubled, right? You also have lowered the number of people with IQs above 128. You have to, right? So this is typically where we think the leaders of a society, the IQs, of the doctors and the nurses, and some people might think the politicians, but not everybody. But the people, people that are really, so this is what's happening, and it's happening in the populations that are least able to sustain that loss of leaders in their population. So it's among the poor, among minorities, among new arrivals in the United States. Those are the highest risk categories, and those are the ones that are losing a lot of leadership. Now, I'm not saying that if your IQ is 120 or 122, that you can't lead a very nice life and contribute to society. Of course you can. It's just tougher, right? It takes a little longer. One of the things that IQ is speed of how fast a thought becomes an action. And it just makes life harder. Up until very recently, we did not understand what was the underlying pathophysiology. We've known since like 3000 BC that people exposed to lead were going to have problems. There was never a question about it. Pliny the Elder wrote about this. But we never really knew why. And this is out of Cincinnati. So here, this is 83 MRIs. Now, if these were normal, and then they put them on top of each other over a standard brain. So a standard brain would be all gray. And these areas, the more yellow it is, the more damage there's been, the more cell loss there's been. These are male brains, and then these are female brains. So let's look at the male brains first because it's easier to see it. And I want you to think about it for a minute. So the things that lead causes is it causes children have problem with impulse control, right? Well, impulse control lives in your prefrontal cortex, right? This is where you make decisions about whether or not you're going to yell at the cop that just pulled you over at the side of the road, right? So you could make a bad decision, you could make a good decision. That's where you make it. These areas are very interesting. So you're hardwired just about to talk. And even profoundly intellectually disabled individuals can make their wishes known in some way. They might point, but many of them, very low IQ, can say, I'm hungry, I'm wet, I'm cold, something like that. You are not wired to read. Reading takes pulling together lots of different areas in your brain. So if you think about reading, you have to be able to identify the letter, put the letter in a word, attach that word to an image, attach that image to an experience. And much of that activity in the brain is going on here and at some of these other areas. So it's not surprising that the things that we see most in children who have negative impacts from being exposed to lead is that they have behavioral problems and they have trouble with language acquisition and use, right? Now, there's something different going on with the girls. We can still see that there are some of these red spots, but they're not, there's nothing like the cellular damage that's here. Now, some people would say that explains a lot. And I don't want to minimize what the damage is. I don't think we really know what these differences are, but we do know that when girls have high blood lead levels, they do not seem to have as many problems later in school as the boys do. We also have, Rick Levin has done a lot of looking at crime statistics across the world, actually, but this looks at crime statistics in the US and blood lead trends. So if you look at the black line, you can see the average blood lead level of preschool children in the United States from about 1935 to about 2013. The red line is the known violent crime rate with a 22-year or 20-year offset. So 2-year-olds don't commit violent crimes, right? And they don't go to prison. But 20-year-olds do, and 24-year-olds do. So what he's found was that in the United States, as the average blood lead level went up in preschool children, 20 years later, the average violent crime rate went up. And then he projected that through 2014. The interesting thing here is that when other people have looked at that and they said, no, it's because the economy's gotten better, right? And they said, well, we tested that hypothesis, right? The economy got worse, but the crime rate, the violent crime rate, continued to go down. And that's true in almost every place in the country except Chicago. Chicago didn't get real serious about their lead problem until the mid-1990s, so it may be that we just haven't seen the results. So the current issues that we're going to talk about today are surveillance, educational for interventions for children affected by lead, the CDC Reference Value of blood lead levels in children, and then I might give a brief overview of lead in water because I know Luke is coming here later today to talk in more detail on that. So this shows you what's happened to blood lead levels since about 1974, when the average blood lead level of children in the United States was 17 micrograms per deciliter, to the last available data of 2016, when the average blood lead level of children in the United States is less than 1, and virtually everybody had a blood lead level of 5 and higher. This is about 0.8% of children have blood lead levels 5 and higher. And this is how it happened. Yeah, I don't know if you can read that, but you'll get a copy of the slide. So we took lead out of, started the phase out of lead out of gasoline. That was a really good idea. Took lead out of plumbing. That was a really good idea. Continued on down till products that are marketed to children are not supposed to have more than 90 parts per million lead. We did the renovation, repair, and repainting rule, which means that if a contractor comes into a house built before 1978 and starts messing around with the paint, whatever that's happening, he is required to clean up after himself. I mean, virtually that's it. He's required to clean up after himself. They really had a hard time with that, but they've begun to accept it. So this looks at the confidence intervals of elevated blood lead levels of children in the United States between 1999 and 2014. And you can see that in 1999, this is the NHANES. It's a two-year survey. We put 4 years together to make the statistics a little more robust. But you can see that the average blood lead level for that period was about 8.65, and then the geometric mean blood lead level then was 4.1, and continued to go down and continued to go down. And then the last one looks at the percent of children who have blood lead levels 3.5 or higher using the 2011 and 2014. So we've brought things way down, and now we're talking about, should we lower the reference value for lead? Should it be lowered from 5 to 3.5? Because reference value, which is a statistics that's used, it's designed to, now let me go back to this for a minute. So reference value is a statistic that's designed when you can't find a safe level. So if you can't find a safe blood lead level for children, which we have not been able to do, what you do is you say, well, somebody who's in the 97.5%, right, the top 2.5% of the distribution, that person's having something's going on with that person that's different from what's going on in the regular population. And that's a signal to me that I need to go look and see what's going on in that child's life that puts him that much higher than most of his age cohort. What it does not say is first off that that child's going to have a negative outcome. So going back to the previous slide, we saw that virtually everybody, and anybody in this room who has gray hair or who doesn't have gray hair but treats it so that it doesn't have gray hair, you had a blood lead level that was 10 or 15 micrograms per deciliter. So how's it working out? How's life working out for you? Okay, right? How did that happen? Well, I can tell you what we think happened is that you didn't have all the other things going on in your life. So I know for myself, I was extraordinarily well educated, right? I also didn't go to McDonald's because they didn't have McDonald's in those days. You know, we ate at home. School lunches were beautiful. So if you want to grow up to be smart, the most important thing to do is to choose your parents well. It's also really important that you make sure you're born into the right zip code, right? Because we know that we can predict life expectancy, life satisfaction, how much money you're going to make by what zip code you were born into. Now, if you have been unfortunate in either of those decisions that you made before you were born, preventing you from having lead exposure is a really good thing. So we need to look at these children and say, okay, which children have a constellation of issues that are impacting their brain? The brain is probably a little more plastic than we've been giving it credit for, but it cannot tolerate repeated assaults, lead, chaotic family, poor education, poor nutrition. These things are cumulative. And lead is one of the things, when you think about all of those factors that make a child successful in life, lead is one of the easiest things to solve, right? So we know how to prevent children from being exposed to lead, and we know which children are being more likely to be exposed to lead, and we even know where they live. So when we think about the reference value, we have a value that, you were talking about the mother who said she'll never forgive herself from having a child with a blood lead level of 4. When I started out in the lead business, the man that ran the lead clinic in Children's Hospital Medical Center in Boston, he was delighted that his daughter had a blood lead level of 15. Okay? Just to understand. So you're dealing with a parent that's got all this guilt and angst, and also perhaps the self-fulfilling prophecy. So what happens if mom says, you know, Johnny's not like everybody, Johnny's not like everybody, Johnny's not like everybody. Pretty soon Johnny's not like everybody, and it's got nothing to do with lead in his environment. It's got to do with the expectations. And you will hear, if you get close to people who are living in Flint, they will tell you that they hear, well, he's leaded. There's nothing you can do about him. Right? And just write the child off. So we need to be very careful when we start using these labels, especially if we have something where we cannot, if you give me 2 classes, kindergarten classes, and you tell me kids in class A, all of them, when they were 2, had blood lead level 5 or higher, and all of them in the second class had a blood lead level that never reached 5, right? I can tell you that these kids are not doing as well as these kids. But I can't tell you that Susie's not going to MIT, right? There's just too many other variables. So we need to be really careful about the labeling thing. And I'm worried that if we lower the reference value to 3.5, we may label children and somehow cause some harm there. The second thing is that, and now this is where you find out that I don't speak entirely from Meridian. So the Comprehensive Laboratory Improvement Act says that whatever kind of blood lead instrument you're using to test children, whether you're sending it to graphite furnace in a laboratory, ICP mass spec, which most of you probably don't have access to, or point of care instrument, it doesn't matter. CLIA says your value could be plus or minus whatever comes up on the instrument, which if you use 5, plus or minus 4 is almost all the numbers between 0 and 10, right? So it's very difficult, just given one test, to even establish whether or not that child is in a high-risk group. So that's another reason to think carefully before we say that children with 3.5, label them as somehow having elevated blood lead levels. And then the final reason that I'm concerned about lowering the blood lead level or the reference value from 5 to 3 is that we know experientially and anecdotally that we can do things that stop the trajectory of the condition. So if we go in and remove lead paint hazards or take the spices away or whatever the source is, we do that, we know we can keep children's blood lead levels from going up, right? But we don't have anything that we know lowers blood lead levels once they're high, right? So once you get up to a blood lead level of 5, nature's going to take its course, and your blood lead level is going to come down in about a year. And that's going to happen regardless of an intervention, right? One of the biggest disappointments in my career was doing a randomized community-based trial of case management, home visiting, nurse home visiting for children with blood lead levels of, at that point, I think it was 10 to 14 micrograms per deciliter, and seeing at the end of the year, everybody's blood lead level was the same, the kids that got the intervention and the kids who didn't. The same is true for chelation therapy and some of the other therapies that we've tried. So that's because a 3-year-old doesn't have the same behaviors as a 2-year-old. Not a lot of hand-to-mouth behavior, maybe they're in center-based daycare, something else has gone on. So given those 3 points, I think it's very difficult to justify, and you guys seem to be ahead of the curve, so maybe this wouldn't be true for you, but in a lot of places in the country, what happens if your child has a blood lead level of 5 micrograms per deciliter now is that somebody sends you a brochure. That's it, right? We're not going to win this war by brochure. So I think it's much more important for us to make sure that we use every interaction with parent and see it as a method for primary prevention. So someone was asking about the questionnaire, the risk questionnaire. The risk questionnaire is a very good educational tool. It's a lousy thing for trying to identify who's at risk, right? The risk questionnaire was my big idea. And in Massachusetts, where we started it, the reason that we had a risk questionnaire is because the insurance companies called up and said, Mary Jean, we're only going to pay for the blood lead tests that you mandate. All right. Well, we said everybody will be tested once a year from 9 months to 6 years old. That was baseline. Now, there were some children, the pediatricians and other healthcare providers thought should be tested more frequently. But the insurance companies told me they weren't going to pay for those more frequent tests. So how was I going to make it so those frequent tests were reimbursable? Well, if you answer yes to any one of those questions, you can get reimbursed for that extra test, all right? So, and this is in Massachusetts, right? Well, I was surprised to see 58% of houses in Utah were built before 1978. In Massachusetts, it's like 82%, right? So there's no child that was asked in all of those questions that wouldn't answer at least one of them yes. So that was the fail-safe. And then there was a whole issue of pediatrics that was devoted to proving that the sensitivity and specificity, words that I, at that point in my life, had never heard before, were like flipping a coin, right? You just might as well just stand in front of the kid and flip the coin and see if it works. So if you want to use a risk questionnaire, I'm not saying it can't be done, but it needs to be done in the context of what's happening in a particular patient population. Do you have a lot of refugee kids? Where are they coming from? Are those the people that are coming usually with the spices, or are those the people that are coming usually with the samovars? Are those, do you live near, I flew over a copper mine. Do they live near the copper mine, or somebody in the family works in the copper mine? Those are the kinds of things that you have to know. And my experience has been that either when you come into a pediatric practice, either you get your height, your weight, and your shot, or you get your height, your weight, your shot, and your blood lead test. because trying to differentiate between the groups of children it's time consuming, and it's just, people do things that are routine. So here's some other, whoops, I'm going the wrong way. I'm still going the wrong way. How can that be? Okay, so one of the things that we've been done a pretty good job at in this country is that we have, this was the gulf between the risk for high blood lead levels in African American children and the risk of high blood lead levels in Mexican American and white children in the United States, right? So this is really a vast disparity. And at least at 10 micrograms per deciliter, or no, this is at the geometric mean, we have been able to reduce that, right? So this doesn't happen in all diseases, and this is because of the regulatory processes and the protections we've put into place that reduce lead sources in the environment of all children. But what happens in many diseases, and you could think about syphilis, it really works well for syphilis, is that all the good things that we've done have marched the entire population's risk for syphilis, to the left of the distribution, right? But leaving the high-risk categories, sex workers, people that are addicted to drugs, with the same risk that they had before these interventions were put into place, right? We didn't do that with lead. We didn't do that because we looked for where the kids had the high blood lead levels and went in there and through the HUD program and other programs tried to systematically identify what's going on in those communities and fix them. So one way to think about how you could integrate primary prevention into your environmental follow-up of children with high blood lead levels, however you're defining them, is if you go into a 4-unit building and the child in Unit 1 has a high blood lead level, well, guess what? The conditions in Units 2, 3, and 4 are probably exactly the same. And if there's no child in that unit now, there will be, because neighborhoods that have children tend to have children, right? And if poor people move in this country, in the United States, poor people move every 6 months. So these properties turn over rapidly, and there is always the opportunity to poison children. I looked at that carefully in Rhode Island, but I'll tell you, I know of a publicly owned housing in Cleveland, Ohio, where there were 700 children identified with blood lead levels 15 or higher over a 10-year period. I don't need to test for child 701 to know that those buildings need to be taken care of. So I urge you to take as your data gets better and better, take a real good look at the addresses. And if the same addresses, or even better if you can do it, if the same property owners come up again and again and again and again, that tells you where to put some of your primary prevention efforts in. Because there are properties out there that they're just lead poison children incubators. So, and then here's the final problem. This is preliminary data, and they taught me that 1 point does not make a trend. But the final reason not to lower the blood lead, the reference value from 3.5 to 5 micrograms, or from 5 micrograms per deciliter to 3.5, excuse me, is because we're getting close to the level of detection for all of these laboratory methods. And so just random error is going to occasionally flip the tail. And you can see here, according to this, in the 2015 and 16 N. Haynes, the 97.5 percentile reference value for lead is higher than it was in the wave before. Now, I'm anxious to see when the data come out in 2018, it usually comes out in January or February, to see if this is a trend or if it's just an anomaly caused by the fact that it's a lot of random error in there. But you can't regulate on a value that's going to change every 4 years. And I know that HUD and EPA will be here next week or the week after, and you probably talk to them about what it means to have a regulatory value, that changes a lot. So I want to talk a little bit about using the CDC blood lead surveillance system. So you guys, the pediatricians, pediatric healthcare providers report to the state. The state eventually reports that to CDC. Extrapolating from our surveillance system at CDC is really difficult. It is not an NHANES. So when somebody says to you, well, we have blood lead levels, we have high blood lead levels 7 times what they have in Flint, you can't really make those comparisons because you don't know who's being tested in Flint or why, or at the state or CDC level, you don't know who's being tested in the local level or why, right? So jurisdictions are required under the CDC grants to target their at-risk population, so that creates a positive bias. Reporting criteria from labs to the state are set by each state and vary across jurisdictions. It's very important that they have to report all blood lead tests, because how are you going to know where the high-risk areas are if you don't know where the low-risk kids live? But not every state requires that. And then the facilities and the diagnostics tests used to conduct blood lead tests vary by jurisdiction. So, you may rely completely on point-of-care testing, and so the level that's reportable, or that's reported out on the instrument is 3.3, right? So you can't just take the 3.3 and add that in and then do a mean on that statistic, because you don't know where that, you don't know, is that 0? Is it a 1? Is it a 2? That doesn't mean that the surveillance systems, either at CDC or at the state or local level, are useless. They give us signals. They don't give us robust, scientifically defensible population-based estimates, but they do tell us a story, and we need to listen to that story. So in Flint, it was a convenience sample. Dr. Hannah Atisha looked at it, and she said, I get 3 times as many kids with blood levels 5 and higher this year as I did last year, and you know what? They changed the water system this year, right? It says this is something that needs to be investigated and needs to be taken in seriously and needs to be looked at. But it's not a way of comparing across different jurisdictions. So this is something, I was telling Randy about this. This is surveillance data that comes out of Cleveland, the home of the Cleveland Clinic. And they were thinking about Cleveland Clinic was thinking about what could they do to help their high-risk populations. And so the county health commissioner walked into the chief executive officer, now the Cleveland Clinic should be somewhere around there, with this map. And this map says that children living in the neighborhood on the doorsteps of the Cleveland Clinic were 16 times more likely to have high blood lead levels than children living in some other parts of the city. And to say that the CEO was distressed by this is to understate it. I mean, he was very, very affected by this map, because these maps that you can do like this tell the tale. And elected officials, policymakers, other decision makers, seeing something like that says, well, what can we do? What can we do? We can do something here, right? And they're still working on it. Hopefully they'll be able to do it. But the reason the Cleveland Clinic and then University Hospitals, not to be outdone, decided to come into the coalition with real money, $20 million, is so that they can put up a sign that says, this lead-safe neighborhood brought to you by the Cleveland Clinic Foundation, right? So I urge you to think about how you can pull in your local foundations by presenting them with a solvable problem, right? It's solvable, you know how to solve it, that will give them the good publicity that they need. So this is, I'm not going to talk about this, I did it a little bit. You can look at the slides later. This is why my big idea doesn't work in the terms of a screening questionnaire. This is the Medicaid EPSDT guidance. You know, you're supposed to have children are supposed to be tested at 1 and 2, or 3 if they've never been tested before. For Medicaid managed cares, providers who are using the HEDIS measure, so that's the report card, 66% of their children are being tested as they should be tested. Now that number has been very stable over the last 10 years or so, but managed care, because managed care people are concerned about their HEDIS measure, if you can get that on your, you can get that arrangement set up, the majority of children enrolled in Medicaid and CHIP, the Children's Health Insurance Program, are covered under managed care. And these guys have a very important role to play in improving lead screening. So 38% of EPSDT eligible children were screened in 2015 overall, but 66% in states that use HEDIS. Okay, so that means that the state health department and the state Medicaid agency have to come to an agreement, and then these data either come from CMS or you can, the national NCQA, the quality assurance people also every year go in, and what they do is they do a chart review, because they're already doing the chart review for immunizations, right? So it's only done at 2. So they can only tell you that 66% of these children were tested by the time they were 2. You know, they can't tell you who was tested at 1 or 2. And that's because it's basically free for them to do that, because they're in the charts already. So I urge you to think about whether or not HEDIS measure is appropriate in this state. And then finally, I was surprised, but I guess I shouldn't have been surprised, that Utah has a lot of new arrivals. Some of them come as refugees, but remember, most of the countries that people come as refugees, there's a whole bunch of people coming as immigrants as well. So their initial blood lead test, the Department of State requires an initial blood lead test on these people less than 16 years old within 90 days of their arrival in the United States. And then again, if they're less than 6, 3 to 6 months after placed in permanent residence. So this is considered a medical necessity, and people who are refugees are Medicaid eligible for at least 6 months. All right. There's a toolkit on the CDC website. You can see the link there that talks a lot about what to do for refugee children and how it should happen. One of the biggest problems is that the resettlement organizations really wants to get people into housing as quickly as possible. And that's their goal. And sometimes it seems as though trying to make sure that housing is lead safe is contradictory, or it's in conflict with getting them into any housing. So it takes a little while to work with them, work through some of that stuff. The reason that these children are most at risk, there are 3 reasons for this. The first is, especially for children coming out of the refugee camps in Africa, they're basically starving, right? So they're not just anemic. Their iron levels are really low, and that's compounded by the fact that many of them have malaria or other parasites. And then finally, depending on where they're coming from, they may be bringing something with them, or there may be something in the ethnic grocery store that's being imported from the country that has lead. It's either been added because it's a spice, it's sold by weight, so you put more lead in it, it's cheaper than the spice, you can sell it, or it's contaminated because the ambient contamination overseas is very high. And then finally, their parents don't know anything about lead paint. The last child who died from lead paint poisoning in New Hampshire, when the Epidemic Intelligence Service officer from CDC came to tell the father what had happened, they were Somali refugees, and the father said to the CDC person, "You mean to tell me that in this country you paint your houses with poison?" Right? So that confluence of those factors really puts these kids at risk. And the other folks, the migrants that are coming from the same countries, have the same problem. So what are the barriers to screening among physicians? Physicians' self-reported influences for lower screening rates is that the parents won't want to do it. They use the screening questionnaire and they don't find anything wrong. They can't get a sample. The patients don't comply. Well, it's really the parents that don't comply. So there's an inverse ratio between if you give a parent a lab slip and tell that parent to go and get the lead test done, some of them don't make it across the hall. More of them don't make it down into the cellar, into the basement, or wherever the on-site facility is, and even fewer make it across town, right? So, and then there's staffing. Women are more likely to screen children. Those who think that there are negative effects are more likely to screen children, and those with more than 55% of Medicaid patients in their practices are more likely to screen. For the Medicaid providers who did not test, they were aware of the requirements, but they believed their practice was low risk. And of those who believed their practice was at low risk, 35% of them were actually in high risk areas. All right, so, and they overestimate the number of children having blood lead tests. So there are very interesting ways that you can approach, the public health people can approach the physicians, and the biggest one is to give them the data, but practice-based data if at all possible. It's not enough to just show them, well, your office is in this area of the city, and we know that children in this area of the city, because they may not draw from that, just from that area of the city. So you have to I'm going to skip that. Okay. So the last thing I want to talk about is lead and educational outcomes. Is there anybody in here that's thinking about getting a PhD? No? Too bad. Okay, well, if that should occur to any of you, before someone ties you down in a chair and says, don't you dare, please get in touch with me, because I get some ideas. But this list of studies that you can see here, and you can review it at your leisure, shows that what happens, what is the educational impact of blood lead levels of certain levels. So you can see that decreased end of grade test scores, 30% more likely to fail the third grade, $0.5 million in excess annual spending on 279 children for special education and juvenile justice in one county in Ohio. So children with the same blood lead level may have different symptoms, right? That's what we talked about. Don't think that Susie's not going to go to MIT. A lot of other factors. Lead is part of cumulative risk. But what basically happens is we don't expect 2-year-olds to have good impulse control. And we don't expect 2-year-olds to have big vocabularies. And we don't expect 2-year-olds to understand the need for higher order planning or organizational skills. These things are expected as children grow. So in the first grade, from the first to the third grade, you're learning to read. And then about the third grade, you start reading to learn, right? And then up to about the 6th grade or the 5th grade, you're memorizing arithmetic facts. And after about the 5th grade or the 6th grade, you're learning to use math concepts, okay? Remember long division? Right? That was using a math concept to solve a problem. And in the 6th or 7th grade, or for some people much later, they start thinking about higher order planning and organizational skills. And well, we can see this in kids who are affected by lead well into their high school and even beginning college years, where you're supposed to be able to integrate information from lots of different places so that you can develop a thesis or a term paper or some other pretty high level thing. So we don't have any published studies. This is what I'm thinking about this PhDs. We don't have any published studies on the effects of children with elevated blood lead levels, but we know that for all at-risk children, for all children who are at risk for school failure, giving them good early childhood education increases IQ up to 8 points, lowers rates of grade retention, less need for special education. We know that these benefits persist up to age 40. And we know that these programs are more effective when the child is less than 36 months old, when they start, and if parents are included. We know that for each dollar for early childhood education programs, you get $2 to $3 back in economic development. That's about the same as when you pay to have a sports complex put in your neighborhood. At the national level, that works out to be about $8.60 in benefits over the working lifetime of these kids. You know, as a former federal official, I want children to be to be successful and to pay taxes. So, this chart is a way of thinking about managing children with lead exposure in school systems, and then I'll end up here. So if children don't show you that they're going to have a problem in school when they're 2, or maybe they don't show you they're going to have a problem in school when they're 4, we need to put together a formal system that keeps track of these children, and so that somebody knows that Mary had a blood level of 5 or 10 when she was 2, and is keeping track and making sure that Mary is making those transitions from learning to read to reading to learn, from memorizing arithmetic facts to using math concepts. And if she's not, there's a safety net there that catches her and provides her the educational support that she needs before she's 2 years behind in grade level. Because in many places, you don't qualify for supplemental education services until you're 2 years behind, right? Well, nobody gets to be 8 twice. And the stuff that you miss, if you're still operating in a 7th grade education level and you're 10, trying to catch up is very, very difficult. So I urge you to think about how you reach out to your next new members of your coalition, which would be your early childhood education, but also to the school systems, so that there's a mechanism in place that addresses the privacy concerns, but also addresses the labeling concerns, but also make sure that the safety net's in place. So I'm not going to talk about lead in drinking water, although I do want to say it's not a new issue, and that's kind of a timeline for lead in drinking water. I don't know if I have time to take any questions. I went over.
Just ask you 2 questions.
Oh, okay. So I have 2 questions that I'm supposed to ask you about. So
It's on your, I think
it's
on the left, the quiz.
yeah, it's on the, it says lead free, yeah. So the CDC blood lead reference value is, and then there are 3 definitions. So circle the one you think is right. Okay. And children with blood lead levels 5 and higher will circle the next answer. Okay, everybody got their answers down? Okay, what's the answer to 1? B. Okay, what's the answer to 2? C. Okay, so I did what I set out to do. And this is my motivational speech. This is a 4-bedroom de-leaded apartment in Brockton, Massachusetts. I want you to think about why the property owner may have de-leaded that property, because he was concerned for the academic performance of the children who are going to live there, because every child in Massachusetts who has a high blood lead level is accompanied by a plaintiff attorney, but also because now they get Section 8, and it's a very good investment for property owners. Okay? I will be around all day. I look forward to getting to talk to you.